Good afternoon, ladies and gentlemen. May I have my first slide, please? Oops. Here we go. Okay, here we go. Ladies and gentlemen, welcome to our workshop on fighting substandard and falsified medicines with rapid screening technologies. My name is Lutz Heide, and I work at the Pharmaceutical Institute of Tübingen University. Our workshop today at the World Health Summit is hosted by the VFA, the Association of Research-Based Pharmaceutical Companies in Germany, by my own university, University of Tübingen, and by EPN, the Ecumenical Pharmaceutical Network based in Nairobi, Kenya. Ladies and gentlemen, substandard and falsified medicines have very detrimental effects. Of course, in the area of health, they increase morbidity and mortality, they increase disease prevalence, they increase antimicrobial resistance, and they lead to a loss of confidence of our patients into the health services. And in addition, they have socioeconomic and economic impacts. The World Health Organization has estimated the number of deaths resulting from the use of such medicines in just two diseases, childhood pneumonia and malaria, to amount to 10,000, even hundreds of thousands of deaths. This is a major global health problem. And when we want to address that problem, one of our tasks is to enable their detection, including detection with rapid screening technologies. Allow me to give you 3 examples of such rapid screening technologies. The Global Pharma Health Fund Minilab has been called a laboratory in a suitcase. It is a kit of equipment, reagents, instructions, which allows you to analyze medicines by visual inspection, by disintegration testing, and especially by thin layer chromatography. And with these techniques, you can get a qualitative and rough semi-quantitative determination of the active ingredient. It is a very robust technology. It's reasonably cheap. One such set, one Minilab, costs around $5,000. It's reasonably simple. You need to train a person for about 5 days to be able to use it. Does not have to be an academically trained person. It's reasonably fast. One analysis may take around 2 hours. And in the last 25 years, more than 1,000 Minilabs have been distributed to more than 100 countries worldwide, making it currently the most widely used screening technology, and it's a tried and tested technology. New technologies are emerging. For example, portable Raman spectrometers. They measure the scattering of monochromatic light from a laser, and the resulting spectrum is characteristic for the active pharmaceutical ingredient and the excipients. They are simple to use. 1 day of training is enough. They are fast. An analysis may take less than 1 minute. The professional devices are expensive. The 2 devices depicted here cost around $65,000. And you need a library of reference spectra, which in reality can present quite a problem. Somewhat similar technique is the use of portable near-infrared spectrometers. Again, you have light shining on the probe, in this case infrared light, and you measure the reflectance, near-infrared light. The spectrum is again characteristic for the API and also quite influenced by the excipients. The technique is as simple and as fast as Raman spectroscopy, but it can be cheaper. The little device which is depicted here is available for just $1,500. Again, you need the library of reference spectra, which can be a problem in practice. The process of doing an analysis is pretty straightforward. If, for example, you want to examine a tablet, you just take a tablet, place it on your spectrometer, record a spectrum, which can be done in seconds, and then you use your computer to compare this spectrum to reference spectra. You can even use your mobile phone and upload the spectrum to a cloud. In both cases, you would get a response telling you whether the spectrum you recorded is actually what you expect from a good quality, authentic medicine, or whether it's not. In practice, things are always a bit more complicated. For example, an easy-to-use, affordable software to run this comparison is still to be developed, and the global spectral library of reference spectra is still to be developed, and these topics will be addressed also today in some of our lectures. So this just as a brief overview. I'm very happy that for today's workshop, we have 5 distinguished speakers. There's Raffaella Ravinetto from Belgium, who will give us an introduction in the public health impact of substandard and falsified medicines, and she will put the integration of prevention, detection, and response in context of the pharmaceutical and health systems. Second speaker will be Rutendo Kuvana from the World Health Organization, who will give us the current perspective of WHO on such technologies. And this will be followed by Céline Caillé and Geza Gnegel from the University of Oxford, who are just developing an online resource to guide national medicine regulators for the selection of the appropriate screening technology. Then Elia Kale from Tanzania will talk about the use of the Global Pharma Health Fund Minilab, which I have used, and especially explain us about the capacity building efforts in the East African community. And finally, Richard Netze will talk about medicine quality assurance in drug procurement by faith-based organizations in Africa, in Asia, and the use of screening technologies in this context. Okay, since we are short with time, we cannot allow questions in between the lectures, but I do really cordially invite all of you to join us in a final discussion. Between the audience and the speakers, we would like your questions, your comments, maybe your experiences. So I would like to ask you during the lectures, please note down your questions for the final discussions, your questions, your comments, your additional thoughts, so that we can all gain from all the experience present in this room. Okay, that's my introduction so far. And I would now like to call upon our, we're not in the right place here. I would now like to call upon our first speaker, Raffaella Ravinetto, who is a professor in pharmaceutical global health in the Institute of Tropical Medicine in Antwerp. Raffaella, please come. Raffaella is a well-known expert worldwide in a field of access to medicines and also quality of medicines. And so we are looking forward to your presentation. Raffaella, over to you.
Thank you very much, Lutz. It's a pleasure and an honor to be part of this panel, so thanks for giving me this opportunity. And indeed, I have a difficult role today because I should try to frame the issue of substandard and falsified medicines and of their detection in the broader picture of pharmaceutical and health system. And I can start saying that quality of medicine has not always been at the center of the concern of public health world. And if we look at this access framework, which was expired by a framework of 1981, they list the factors that affect the ability of patients to get the medicines they need. And you have adequacy of medicines, availability, geographical accessibility, you have affordability to individual and to the states, you have acceptability, everything is very good, but you don't see quality there. And if I get a medicine which is underdosed or which is contaminated with diethylene glycol, I'm not getting the medicines that I need. But it used not to be considered that much by researchers and policymakers. In 2024, we are more concerned about that. This is a four-path way that with some other colleagues from 4 different continents, we proposed at the beginning of this year as a way to shape the future of global access to medicine and other health technologies. And we are clearly putting the accent in blue on quality. And it's not quality as such, is that there is a call to strengthen the regulatory systems, the regulatory authorities, harmonization system, and to strengthen the supply system as a way to prevent that poor quality medicine can enter a market and can enter the supply chain. So there is something positive. Over 40 years, policymakers became available that quality of medicine is not something which is magically ensured by somebody. And I have to say, when I was a young pharmacist in Doctors Without Borders, my master pharmacist called Jacques Pinel told me, you see, traditional people think that somebody, somewhere, somehow, has checked that the medicine is good. Nobody knows how. They just trust the system. And trust is the fil rouge of this forum. And sometimes you should not really trust the medicines you get. As the WHO estimated in 2017, about 10.5% of medicines available in low middle income countries are not of good quality. You cannot trust them. So that's a real problem. Somebody told me, 10% is not that much. Well, 1 person in 10 will get something which doesn't work, or which is even toxic. So we have a problem. Just a quick overview for those who are not familiar. The WHO in 2017 also provided a very good and agreed definition of what are these medicines of poor quality. And I'm starting from the bottom of my slides, because usually it's easier to explain, at least for lay people and journalists. I don't know if there are journalists in the room. We have unlicensed medicines and other medical products. These are medicines we just skipped the regulatory checks, so we don't know their quality. Sometimes we do not even know their origin. Then we have falsified medicine, and that's always something which is done with a criminal intent. So somebody on purpose put on the supply chain something which pretend to be something which is not. Substandard medicines are the trickiest one, probably, because these medicines have been registered, have received an authorization from the relevant regulatory authority, but due to mistakes or negligence in production, or sometimes deterioration, they do not comply with adequate standard, which is not just a technical formal thing. It can mean underdosing, it can mean not bioavailability, it can be toxicity. So this is, for instance, substandard medicines, a paracetamol which was regularly, legitimately in this country, but it was really very much deteriorated without being expired. And this is a very new case of falsified medicines. It's a falsified Ozempic from Novo Nordisk. This is from a news of last week. And these are medicines where if I convinced you that you don't have necessarily to trust the system, now you look at them and you ask yourself, are these good medicine, are these not good medicines? Lutz already mentioned fighting substandard and falsified medicine. It's a complex issue. It's not only about detection. WHO, again, provide us very good guidance. They tell us that we have to prevent, and you prevent through a complex system of quality assurance, which look at the product dossier. So you start from the design of each individual product. You check that there are good practices respected during the manufacturing, and on the supply chain, good storage and distribution practices. If this set of good practices was ensured everywhere, we wouldn't have substandard and falsified medicines. Of course, no system is 100% safe, some even less, so the possibility remains that you have medicines of poor quality on the market. And you may be aware of this. Between 2022 and 2023, there have been hundreds of cases of oral solution for small children contaminated with diethylene and glycol, which caused thousands of deaths in small children. And it was initially the Gambia, Indonesia, Uzbekistan, so we had the three WHO region, but now we have more than 10 cases reported to the WHO, the most recent one in Pakistan just last week before coming here. So this must be prevented. We cannot accept that the child die because of a contaminated syrup. In the past, some academics said we should identify which are the products more at risk and concentrate our effort on those products, like antiretrovirals or antibiotics. But in fact, here, kids died because they took a cough syrup or a paracetamol syrup. So if the quality assurance system doesn't work, the risks are ubiquitous, are always there. And yeah, and you have to avoid, this is unfortunately, I don't know where this photo was taken in France, but for those who speak France, you have the doctor, the pharmacy, and the cemetery. So this is what we would like to avoid. So in this sense, we would like to prevent. We cannot prevent all the time, so we need detection. We need these experts sitting in the first row to be able to deploy rapid screen in the field to be helpful, to help to detect the medicines. This is not a magic solution. This cannot replace the big prevention and quality assurance system, but this can be a very important tool to support the regulators with post-marketing surveillance, which can be routine, which can be reactive to an accident. It can also be used by operational actors, like Richard Nesi will explain us afterwards. And it can also be used by researchers. There are a number of researchers who are, like the group of Céline Caillet here, who are engaging in doing quality surveys, prospective in the field to understand the prevalence and characteristic of poor quality medicines by country and to orient the response of the regulators. I wouldn't use them to pre-select our suppliers because, of course, a rapid test gives us a photo at a given moment. They cannot tell us, for instance, how a given manufacturer assures continuity of quality. I am approaching the end of my presentation. It's also important to know that everybody who's going to use these tools in the field has an ethical obligation, I think, to share their finding with the regulatory authority in the country, because this information, especially if you find suspect poor quality medicines, that must be shared with the regulatory authority to immediately implement corrective action. And something very important, perhaps my last and most important message, you cannot enforce quality if you also don't enforce access to medicines. Whenever a country has a too small pharmaceutical budget, they will be pushed to buying too cheap and perhaps not quality assured medicines, substandard. As long as a family doesn't have access to good medicines, they will be pushed to the illegal market. And of course, the risk of falsification is quite high. So we have to integrate this fight in the fight for access to good medicine for all. Access and quality goes together hand in hand. And we have, and this is for the important people at this forum, we have to make an effort to convince our government, our donors, other policymakers that they don't have to oversimplify the work on poor quality medicines. It's a complex thing. Prevention, detection, response. quality assurance, quality control, regulation, access. So we must be able to adapt our language, not to speak too much technicality, to be able to explain the donor and the Ministry of Health that investment must be equally spread over the different components if we want, at the end of the day, protect individual health and protect public health. I hope that despite my Italian nature, I managed to respect my 10 days, Luz, and I give you the chair back.
Thank you very much, Raffaela, for this very good insight, which I think gave us a perfect framework to start our session today. I will now call up the second speaker. Our second speaker will be Rutendo Kuvana from the World Health Organization, and I'm especially happy that he agreed, despite being in India on a meeting in a moment, to be with us, because he is possibly the most important person for their subject on the world. He, in Geneva, has a task to head a small team which is responsible to address, to guide the worldwide efforts to counteract substandard and falsified medicines. So I think you are an ideal speaker for us on our meeting. Thank you for being here, and we look forward to your presentation.
Thank you very much, Lutz, and I hope you can hear me very well.
Yes.
Thank you very much. And also, thank you very much for the invitation. I think this is a very important meeting, also a very important subject for us to contribute. And as introduced by Lutz, I am in India. This week, we have the meeting of all the medicine regulators, so it's called the International Conference for Drug Regulatory Authorities. And one of the subjects that has been described a lot this week is the issue of substandard and falsified medical products. If I could have the first slide, please. Thank you very much. And also following up from what Raffaela was talking about, we consider the three main pillars for our strategy to fight substandard and falsified is, again, the prevention, detection, and response pillars, as we call them. And under the detection, we have several components that we are looking at. We are looking at controls of imports and export, that is border control. We are also looking at improving the reporting systems, risk-based inspection and surveillance, but most importantly, access to laboratories when there's need, and also screening technology so that, especially for those systems where you might not have a fully fledged laboratory, or you might not have you might want to do it in stages so that you are careful on the use of the resources that you have. In the next slide, I just want to introduce something that we did with the member states. So we got in touch with the different countries, members of WHO. So we received 87 responses from the countries. We're expecting 194, but we only received 87. Unfortunately, only 22 of those surveys were responded to in full. The question that we're asking really was, amongst other things, in the next slide, we were doing an analysis to find out what are the major challenges that countries are having or that they anticipate to have in their fight to establish a system that can be used to detect substandard and falsified medical products. So you can see there's a whole list of reasons that they provided to us, and amongst them is not enough recognition or understanding of the problems. In other words, countries were not very clear what the problems were. They really don't understand for them to be able to come up with a proper solution. In addition to that, countries reported that they did not have adequate technical knowledge within the government systems to know how to develop a workable regulation. In other words, they don't know how to regulate the situation where they can actually detect these substandard and falsified medical products. In other issues, it was not enough technical information on how to actually develop a system that's viable, that give you the correct results when you need them at the right time. Also, in some instances, there's no adequate regulation of the system, so therefore it becomes difficult. And you can see right there at the bottom is also, but it's not a lot. We also see that in some instances there was political opposition to the need to develop a detection system. The reasons were not provided, but it's interesting that there was also some political influence there. So what we had then decided was it would appear that the challenge that the countries have is actually to decide on which device to use. My colleagues from Oxford will talk about some work that they are doing to try and identify detection technologies that are out there. But for us at WHO, we have decided that in the next slide, we are looking at a guidance that we are working on, which provides guidance to the countries on how best they can select and use technologies. Which is the best technology to use? Do you use the mini lab that Lutz was talking about, or do you use the near infrared device, which is only 1,500? And when is it best to use that device? So that's what the guidance that we are working on as WHO will provide. We also do realize that there are some technologies which are not available. So we are also working on a guideline, or what we call in the next slide, a technical target product profile, where we are looking at, if you are going to have a handheld device, what will be the optimum requirements that it must have so that it can be used? And we are hoping that once we have this target product profile, this is what the developers or manufacturers of these products can actually use to, when they go to the countries, they already know what the countries need on the basis of these needs that are expressed in this document, and then they can use them. Lutz also presented, and he did mention the fact that there are so many devices that can use near-infrared Raman spectroscopy. And so what we have realized is all these, as he said also, you need a reference library. Now, the question is, you have all these devices that have many different libraries that are installed in them. Excuse me. That are installed in them, and you have different markets. So what we are looking at in my next slide is WHO. I'm just going to talk about a global library that it's a future vision that we have as WHO, where we're looking at developing a global spectral library that can be used for rapid screening of substandard and falsified medical products. So the same devices that Lutz was presenting. And then, so the idea is in the next slide, we are looking at the devices being used to scan the tablet, scan the powder. This is the handheld device, so that becomes the data source. And then that scan is sent to the WHO sent to the WHO database or solution where there's the library and it's online or offline, and anybody can send their spectrum. And we also have the chemometric or the algorithms that will analyze that spectrum so that it's indicated as a match or it's not a match. And then you have the processed outcomes or the results. And then the person on the other side, be it in the country, in the field, then gets the results, and then they make a decision. So this is something that we are looking at as WHO to actually establish whether this is a viable option that we can offer, especially to those countries that cannot afford to buy their own devices. So this is one thing. And if you look at the slides, next slide, sorry. If you look at my next slide, I just want to talk about some of the things that we see as future challenges that might be impacting the countries. So in the next slide, there are two challenges that I'm highlighting here. The first is the use of online pharmacies or e-commerce platforms, including the dark web. So the problem is People are not going to physical pharmacies, physical hospitals and clinics. There's more purchase of medicines online, and then they are shipped directly to the house. So how can we detect substandard and falsified medical products when there's online sale and there's no one who is an interface between those suppliers? So it's anonymous and it's easy, and most people are going for it. And this is again something that came during COVID. So this is a problem for us, and we have to determine and we have to work with various partners to determine which technologies to use. Again, some of the people we are looking at personalized medicine, so an increase in demand for personalized medicines where you have a headache, I don't give you one paracetamol, maybe I give you a quarter, half a tablet, depending on your personal needs. So technology is going that way, and it's going to be a challenge for us to be able to manage that using the detection technologies. In the next slide, I talk about the use of artificial intelligence. It's a major topic here at the conference for the regulatory authorities. Everybody's talking about artificial intelligence and machine learning. So it's becoming much easier for the people who are making the falsified or fake medicines to use artificial intelligence and machine learning to improve their falsification of products. Now, the strategy that is required is for the regulators to be able to respond to this using detection technologies that can actually beat what the other technologies that have been used. So there's a lot of catching up that the regulators need to work on, and this is something that we are discussing here with the regulatory authorities in India, and this is something that WHO will continue to support. So thank you very much for your time, and I revert back to the chair of the session. Thank you, Liz.
So, thank you so much, Rotendo, for this very good insight and overview of how WHO is currently approaching these questions. We learned a lot, and I hope that you might even be able to be with us during the session and join the final discussion. So there will be additional questions coming up there. Thank you. I will now open our next presentation. And I will call upon our next speakers, who are Céline Caillé and Gesa Gnegel from the Medicine Quality Research Group on the University of Oxford, probably the most active academic group worldwide, working on the field of substandard and falsified medicines. They are very important for us as they are right now in this moment developing an online resource which can guide regulators to identify the appropriate technology for them. So we're very curious to learn about your progress and where you stand and how it's going. Okay.
Thank you very much, Lutz, and good afternoon. So we've heard from the previous speakers that detection is a key pillar in the fight against SF medicines, and I'm not going to come back to that. But in an ideal world, all national medicines regulatory authorities would have well-equipped and a laboratory and enough resources to do post-market surveillance activities. But in reality, that's not the case in many countries where substandard and falsified medicines are prevalent. There has been a recent increasing interest on portable screening technologies as a way to rapidly, easily, and in a reasonably cheap manner to identify suspicious medicines before they are taken to the lab for a confirmatory analysis. And when you look out there, there is quite a lot of different devices that could work for that purpose. That is just a very small subset of them. And there is growing literature, so growing evidence on the performances and the pluses and minuses of these devices. But we know there is no one single device that will work to test the quality of the variety of medicines available on the markets. So that leaves medicines regulatory authorities and decision makers with a big question mark as to what device to use for their specific purpose and settings. So our group is working on compiling and translating the available scientific information into understandable and meaningful evidence for decision makers to, as a guide to select for the best screening technologies. We hope this work will also inform on research needs and on future research on screening devices. How we do this? We use the data we collected in a previous study, in a systematic review published in 2018 by our group. And we have developed, in alignment with the WHO guidance document mentioned by Rutendo earlier, online interactive platform that we also call Dashboard, but it recently got a name. It's now called Daffodil. And my colleague is going to give you a tour of it later. Now, how a big piece of the work we've been doing so far is gathering regulators, decision makers together in different events, together with researchers and key institutions like the WHO, to understand the needs. What do they want to see on Daffodil? How do they want to see it? How is it useful to them? And soon we will start an assessment of the utility and usability of Daffodil. And please, if you, a colleague or collaborator, is interested in contributing to this assessment, contact us. And we are planning to release Daffodil online by April 2025. So I stop working for now, and I will leave the floor to my colleague Giza, who will give you a tour of Daffodil that was developed, the prototype Daffodil developed by our team. Thank you.
Okay, thank you. So it's now my pleasure to walk you through Daffodil. As mentioned by Celine, we will make Daffodil available online. So once a dashboard user is typing in the respective URL into their web browser, this is what they see, the welcome page. We have designed the welcome page to give a quick and graphic overview over some key information from the dashboard. For example, how many devices the dashboard currently captures, how many scientific publications we have been extracting data from, or which types of technologies are currently most prominent among screening technologies. Please note, work is still ongoing, so these numbers and figures are not final. Changes are still possible. After the welcome page, dashboard users could then open the devices subpage, which really is the core section of the dashboard, and set up in a manner to support dashboard users to find devices that will suit their need. We therefore have implemented a so-called match score function, and as soon as dashboard users start selecting one or even several of their requirements on a device, a match score will be calculated. Let me show you how this works. So here I have selected a few requirements. I have ticked a size group indicating that I'm interested in devices smaller than 20 centimeters only. I have selected that I only want to see devices which are currently on the market, and I have chosen an electricity requirement, which is battery-powered devices. Something you have noted for sure is that on the right-hand side now a table has appeared with lots of devices. And for each of those devices, Daffodil has calculated a match score saying how well this device complies with my requirements selected on the left-hand side. And as you can see, Daffodil identified 3 devices which comply 100% with my 3 requirements. This small table already contains quite some helpful information, but of course there's more information in Daffodil, so let me show you how to access that. One way is to modify the table columns by clicking into this field, which will then cause this drop-down list to open. And here I can select additional table columns or unselect table columns, which are currently shown. For example, I could now click on formulation, and then I have an additional table column on the right-hand side, which now informs me if the device has been tested on tablets, capsules, or other types of formulation in scientific literature so far. Another way to access more information is to select those 2 or even 5 devices I'm interested in most, and then hit the Compare button. This will prompt this pop-up window, allowing a really in-depth comparison of the devices which are of interest. Apart from the match score function, we have also implemented a filter function. It works a bit similar but differently. So you can see I have selected the same 3 requirements on the left-hand side, but now on the right-hand side, the list is pretty short. The dashboard is only showing those 3 devices which fully comply with my 3 requirements. So everything else is hidden. Next to the devices subpage, we have the subpage for the scientific publications, where we list all the, at the moment, 84 publications we've been reading. And for the convenience of the dashboard users, we also try to provide links to the web pages of all the journals. Our newest feature is the Contribute subpage, where we invite users of Daffodil to participate. People who are using screening technologies on their own are warmly invited to provide a review by filling our form, and this can be either done by typing in a text or by providing a 1 to 5 star review. Our fellow researchers are very much invited to upload their own research findings. And other Daffodil users, such as manufacturers of screening devices or other users, are provided with an email address so they can let us know in case they spot anything that seems not to be correct. And that was the short tour through Daffodil.
Thank you very much, Gesa, for this very nice tour, giving us an overview, and to Celine for her introduction to the topic and how it all fits together. I am quite sure that especially your lecture may attract a lot of questions in our final discussion. Please note down any questions or comments you might have. Okay. Let's move away from Europe and let's move to Africa. I'm very happy to welcome among us Professor Eliangiringa Kale, who is Professor of Pharmaceutical Quality Assurance and Pharmaceutical Regulation at the Muhimbili University of Health and Allied Sciences in Dar es Salaam. He is possibly on the African continent the most well-known person, or most well-known researcher in the field of substandard and falsified medicines and medicine regulation. And he comes from the country of Tanzania, which may probably claim to be the country with the most long-standing history in the use of screening devices for detecting substandard and falsified medicines. And maybe that could be one of the reasons why Tanzania actually was or may have contributed to the fact that Tanzania in sub-Saharan Africa was the first country to achieve with its medicine regulatory agency the prestigious World Health Organization maturity level. Thank you, my friend. Maturity level 3. So that was quite an achievement for Tanzania, I think, and you witnessed all that. And Elia, we are looking forward to your presentation.
Thank you very much, Chair, and thank you for a very eloquent introduction. I wish my mother was here to listen to that. Yeah. So I'm going to share our experience from Tanzania and more so in the Eastern Africa in the deployment of the rapid screening technology. And here I'm going to focus more on the mini lab. And I will take you through the way we tackled the approach, whereby we introduced this way back around 2000. And Tanzania, as the chair said, it was the first country to pilot the use of the mini lab as an important tool or component for post-marketing surveillance, and with the objective of adapting, because we are resource constraint setting, to deploy the potential of the simplicity of this rapid screen technology to be able to fix our problem that we are facing of substandard and falsified medical products. So in the introduction, the intervention was supported by USAID and it was implemented by MSH. So basically, which is, I think, very unique, and what I'm going to present here is the involvement, the approach that we used. So there was involvement of our national regulatory authority, the deployer, or the enforcement of medicine quality, and our university is a generator of skilled personnel. So the project involved both of these institutions for a very basic reason of having, at the end of the project, to have sustainable generation of skilled workforce to continue to supply the market. So what support, kind of support went to the National Regulatory Authority? One, it was supported with infrastructure, a provision of the kits themselves to be deployed on the field, but also it came with a package of capacity building, training of staff, the inspectors and analysts, a development of critical documents to support the system. Here we are talking about inspector's manual, we are talking about SOP, and also different reporting forms during post-marketing surveillance. And then also, which was also very unique to this particular initiative, was the capacity building to train the inspectors and the analysts in the deployment. And like any other technology, one-time training might not be necessarily to get the required proficiency. So what we did a first round of training, and then we deployed the inspectors in the field, and then we developed a proficiency testing scheme to follow up on them. And we saw in round one, which is reported in the publication that you see down there, out of the 29 inspectors, only 3 of them in round one were able to identify defective products. So which means, in a way, this is a training needs assessment or gap assessment. So what was the intervention which follows then was to develop an intervention to retrain. So we had a second round of retraining, and then again it was followed by proficiency testing. And this after the second retraining, is 19 out of 28 inspectors were able to identify the defective product. So I think both of these are published so that other countries can learn from it. And we think it's a good practice for others to learn. And then for the university involvement, what was provided? So for the university, we were provided with a kit, and basically to use it for our in-service training, so that we have continuous supply of skilled personnel who will continue to be deployed by our regulator. And in order to do so, we have to incorporate it in our curriculum. So we did that to incorporate the mini lab as a part of our undergraduate training curriculum. And you can see on the right there is an extract from our curriculum where the mini lab featured. So in so doing, we were sure of continuous and sustainable production of skilled inspectors and analysts who will be able to operate the kit. And then after this, we also have a couple of other trainings. So now our university was used as a training center to tap on the multiplier effect. And we trained in Tanzania, we have our education, we have a degree level, we have a diploma, which is more of technical education. But all of these, they are also employed with our regulatory authority as inspector or as analyst. So in another effort that was supported by Action Media, it focused on capacity building for the tutors of these lower cadre training institutions so that they can also learn these technologies and also incorporate them in their training. And then after this, many countries within the East African region adopted the technique. And with the support of different donors, including PTB from Germany, we conducted several training in Zanzibar, in Rwanda, in Burundi, in Kenya, whereby the technologies were adopted. And several post-marketing surveillance were conducted by using the mini-lab, and there's a lot of report which are available in the publications. Of recent is also another similar approach, which also started with University of Rwanda, a training of trainers, all pulled from the East African community countries. And again, also providing the member states with the kits, 16 of them were provided, in order to strengthen the post-marketing surveillance. So, and this is started with the training of trainers at the EAC level, and then followed by individual country training, and we trained a number of analysts. And later, these ones are going to be deployed in the post-marketing surveillance, which is joint in the same spirit of harmonization. As you've heard that there's a number of other rapid technologies which are emerging, we also did not stay back. We also rapidly adapting with our training, and we participated in a pilot curriculum for universities to introduce SF curriculum, and WHO donated the near-infrared pill scan in order we can incorporate it in training of undergraduate students. And again, it started with the training of university staff on how to use the technologies. And then later, they were, the staff can be used to train the students. And then in another initiative, we are working with the PQM Plus, and again, there is an online-based tool for planning and execution of post-marketing surveillance, which is risk-based. And again, our university was used as a center, whereby we started with the capacity building for the use of the MediaRISE, which is the risk-based online tool. And then after this, our university staff were used to train inspectors and analysts from the IGAD and from East African community. And in so doing, we hope this approach will promote sustainable and the domestication of such technology within the region. So I can conclude by saying the capacity building efforts around the mini lab have significantly enhanced pharmaceutical quality assurance. And as I guess, as the chair has said, you are aware that Tanzania was one of the countries to be designated as maturity level 3. And I think thanks to a lot of effort that has gone to build the regulatory capacity. And then to continue sustaining and build on this achievement, we need collaboration. So we call upon all interested partners to join hands in order to continue building the capacity. And again, we should not leave exploring the emerging technologies like we have seen them. Every day the new technologies are coming with the simplicity and the use of use. We should also take advantage of that. And having said that, this brings us to the end of my presentation.
Thank you so much, Elia Kale, for this enlightening presentation, really showing the efforts which you have taken in Tanzania and in all the East African community. And thanks for reminding us that it's not enough to make a technology available. Training in its use, I think, is the real cornerstone to make it eventually successful. Okay. I will now move on to our next speaker. And I'm very happy that we have among us Richard Natesi, who is the Executive Director of the Ecumenical Pharmaceutical Network, based in Nairobi, Kenya, but comprising a high number of faith-based, church-related organizations who actually, most of them, procure medicines and supply them to health facilities in Africa and Asia. And here we are really approaching the patient directly. For these organizations, making sure that their medicines have the correct quality is of utmost importance. And we look forward to your presentation and your experiences. Richard.
Thank you, Professor Lut, for the presentation. I will share the work of Ecumenical Pharmaceutical Network, but we do this work related to the quality of medicines in the Church Health System with our partner DFAM, the German Institute for Medical Mission. And the network, Ecumenical Pharmaceutical Network, is a network supporting the Church Health System in Africa. We have 141 members, and these members are Christian health associations. The Christian health associations are the umbrella organization of all the faith-based health facilities in the countries. In a country like Nigeria, the faith-based facilities are almost 500, 600, 700 in some countries. In Tanzania, up to 900 health facilities belongs to the faith network. And in some of these countries, the overall provision of healthcare is up to 40% of healthcare in the country. So this is an important contribution to the health system in these countries. And because we have many facilities, and because sometimes we don't access directly to the public national supply system, the church decided to create the unit, which we call Drug Supply Organization, to coordinate the supply of medicines in these countries. And I will share some of the practices and the challenges and how the mini lab is one of these tools is supporting to make sure that the products which are entering the Church Health System are of good quality. But what are the challenges? One of them is the level of maturities. These DSOs, drug supply organizations, are at different levels. Some are really well developed with WHO pre-qualification, like MEDS in Kenya, their lab is WHO pre-qualified. They have ISCO pre-qualification. They have OFDA, USAID pre-qualification as a humanitarian center, and so on. But on the other side, you have countries where they are not qualified, but they are the only one source for supply of medicines in the country, like one in Central Africa Republic, which is the main supplier of medicine in the country, but at a very lower standard in terms of quality, in terms of quality assurance, in terms of procurement practices, and so on. But also they are facing other types of challenges. Most of our health facilities are in rural area, where the capacity to buy is very small. So everyone is under pressure to have cheaper product, cheaper prices, to make the healthcare affordable. And where we have drug supply organizations, sometimes they are not buying product through those drug supply organizations. They go to the private market with many risks of unethical business practices. And because of all these challenges, but also some of them are not able to sustain the budget, to the capital, the medicine capitals, to replenish the stock on time. So all these challenges are we're putting the facilities in the risk of buying substandard and falsified medicines. So EPN with DFAM, we developed a network of mini-lab in different countries, Francophone, Anglophone countries in sub-Saharan Africa, but also in India. And these mini-labs are playing a key role in making sure that the products which are entering the CHF facilities are of good quality. You can see all along the way how many samples have been tested. In 2015, all of them tested almost 1,100 samples. In 2023, up to 1,760 samples tested in different countries in Africa. Actually, they are operating in 13 countries in the continent. I want to give just a few snapshots of the result. This is 2023. We try to focus on the product which we think are impacting the health system. Rafaela mentioned that we need to focus on all. You can say we focus on antibiotic, but the risk will come from just a syrup, a simple product for the normal condition for the kids. So we try to make sure we focus on those products which would have impact on healthcare, but also on the overall public health. That's why antibiotics are some of those priorities. And you can see in the number of products tested in blue, most are antibiotics, antibacterial products, but also we focus on other diseases like cardiovascular products and many others. The results, as you can see, out of 1,760 samples tested in different countries, the main issue was found in different countries. You see Nigeria is one of them, DRC, Cameroon, and the overall number or percentage of products which are fake or substandard, you can see out of 1,760, 42 of them were substandard or falsified. And this make a total of almost 4% of the overall product, 3.2% were non-compliant. And here I just want to show you, because we try to go beyond our own health facilities. And we sample from our own faith-based facilities. You can see that the percentage of substandard product is almost 0.9%. The public health facilities, the same, 0.9%. Our own stock as drug supply organizations, up to 1% have been found in 2023 as substandard, which is also one of the key factors to show that we are still facing risk in our own supply system because of some of those gaps in terms of capacity to do good practices in procurement, but also some of the gaps are relative to the pre-qualification of suppliers, which make it really difficult to make sure we are buying the product from the right sources. The high risk is from the licensed private sectors, vendors, but also the unlicensed. You can see up to 4.2% of all the tested product from the licensed private vendor, and almost 8% in unlicensed vendors were found substandard. So the risk is very high in the private market, but especially those who are not allowed to sell medicines, but they are in the market and they provide good incentives to the facilities to buy from them. So the overall is 3.2%, but this shows also the risk in the market in the countries where you find up to 4%, 8% of product are non-compliant. And the most falsified or substandard product has been, again, antibacterials. Maybe because we sampled the higher number, and you can find also the higher number. And I hope it would be the same if we collected the same number of samples in all the different category of products. This is a case in Cameroon where the product is NAFDAC. NAFDAC is the regulator in Nigeria. The product has a registration number of NAFDAC, but when it was discovered, we found that it was not in the system of NAFDAC. But the same product is not, it was not discovered in Nigeria, it was discovered in Cameroon. So you can see the risk of the cross-border between one country to another. So you can't clearly say, was this product falsified in Cameroon or it came from Nigeria to Cameroon? So those are some of the questions which really need to be discussed. But what EPN is doing, we try to support them increase the capacity, because we have found that if they increase their capacity to test, we have also the good data on the quality of drugs in the countries. But also we have developed an assessment tool for drug supply organizations so that we can look at different components and make sure that they meet the minimum standard, especially on procurement. We found that the gaps are in procurement and the overall quality assurance system. So we try to look at that and provide technical support so that they can improve. But also on the side of training, mentorship, to make sure that they are also increasing the best practices in the supply chain functions. We share the tools. Kenya, for a country, Nigeria or Chad, when they are trying to struggle how to put in place the right system, we try to connect them with other members so that they can get easily the tools and not starting from scratch. And we have seen that this is really supporting them improve fast their capacities. But now we are working on a supplier database because not all of them are able to conduct the inspection of manufacturing sites, to conduct the pre-qualification of suppliers. So those who are able, we try to use the data from them to share that information with others. Actually, we are building a database which will be supporting the members when they want to know this supplier has been tested, inspected, what are the quality of product, which sites are approved. So we are working on that. It requires resources. We said we are going to start and continue raising more resources so that we can have a robust supplier database for our members. So that's it, but also we are working on pool procurement to ensure that we can buy together. We have it established already for East Africa, and we are looking to expand it in the continent. So I will end here saying that, yeah, the mini lab, using it in the system has really improved awareness, actually many facilities, after seeing the risk, they understand that quality should pass before price, because price sometimes is not the right factor, which is the only one guiding decision, the guiding criteria when facilities want to buy product. Actually, they have moved and say not only the price, but making sure the product also come from the right source. But also, I think it has supported their collaboration with decision makers, regulators, and also we provide evidences. We have seen some countries, from our data, they were able to act quickly, but unfortunately, it's not the case everywhere. In other countries, you share the result, you share even the source of the substandard product, but no action is taken. Up to 3 months, without any action, the product continue to move in the market. But also, the mini-lab has really increased our ability to communicate, to engage members across countries, share data. It's easy for us when a member discovers a substandard product to check in other countries very quickly and inform the entire network what is going on, but also the regulators. But also our work is connected to WHO. So some of our, when we found the substandard product through DFAM, we report to WHO to raise international alert. I think we need to explore new technologies. We think it's a need, and that's why the work, ongoing work with colleagues from Oxford is very important, so that we can diversify the tools and make sure that the entire continent, we are working in 27 countries, but the mini-lab is only in 13 countries, so there is still a lot to do to reach the continent. But also, we think it's important to continue advocating. One of the reasons we should continue to advocate is because our regulators, the post-marketing surveillance is underfunded, and no donor would like to support. They say it's the mandate of the country, while our own budgets are not sufficient to really engage in post-marketing surveillance. So we need to continue advocating, but also at every level to ensure that we are not forgetting that part, which is important to ensure the last mile facilities get the right product. And finally, I would just say we appreciate the collaboration with academia. I think since we have started collaborating with the University of Tübingen, a lot of awareness has been created around the work we are doing, but also the overall quality of medicines in our different settings. So I will stop here with the round of some of our DSOs in Uganda, in Zambia, in Kenya, which is WHO pre-qualified as a quality control lab, and in DRC and Liberia. Thank you.
Thank you, Richard, so much for putting that in a perspective of real practical application, where really drugs are procured, brought to the health facilities, and how the detection of substandard and falsified medicines is brought into that system. I admire the work of Ecumenical Pharmaceutical Network very much, and I hope we can continue collaborating in future. Okay. This brings us to the end of our presentation. I would now like to invite our speakers to come forward to the podium and take their places in a podium. And we will have the chance to engage in a discussion. And I would really cordially invite you from the audience both to ask clarifying questions to individual speakers or just in general, and we'll see who will be best able to answer them, but also to give additional comments or add your experience here. Just a technicality, you remember that our session is also streamed over the internet, and people are listening to us online. So when you want to raise a remark, make sure you wait until you obtain the microphone, because otherwise our people joining us online would not be able to hear your question. Okay, I do have a few questions myself already, but I think I should step back and would first like to give chances to people in our audience, and I already see a gentleman over there, and then two ladies here asking questions, and you, okay?
Yeah, thank you very much. First, to thank all the presenters for really a very important topic that has been well presented. I'm Ibrahim Alabi, and I'm from Nigeria, so I lived and work in the developing world. And I've had experience working in Liberia, Gabon, and also in the Gambia. And issue of falsified or substandard drugs, really this is very, very, it's a time bomb really, and has been of very many negative effects, really. People sell drugs on the street, in the market, and the regulation is really very low. So in Europe, on developed world, you need a prescription to buy antibiotics in particular. But in our countries, this is not the case. And those who is in the law book, but people do it freely. And there's no means of enforcement. So we have regulatory agencies, but they can't enforce. So what I want to ask this panel, this is a very good effort, and it's worthwhile, but how do you enforce that saboteurs don't go around, or people who are already doing this trade? It's a cartel. In Nigeria, they fought this so much that they almost killed one of our ministers for fighting fake drugs. So this is why we have this NAFDAC sign to show authentic drugs. And I'm surprised that in Cameroon now you have NAFDAC sign, but the drug is still fake. So somebody is manipulating it. So first is the issue of enforcement. And second is the issue of capital, of funding. I work in Liberia, and at the time I was working there, it's in the rural place. To get a pharmacy shop, you will move at least 30 kilometers. So there was a workshop we were doing, and then we were showing, don't buy fake drugs, don't buy fake drugs. And one of them said, we don't have any place to buy the right drugs. This is the situation, really. I just want that we can brainstorm on this. Thank you very much.
Thank you. This important question of, okay, you have tried prevention, you have tried detection, but response can be a problem. How do you react? Maybe I would address this first to Richard, possibly, because I think you already alluded to that problem, and then possibly Rutendo could also, from his experience talking with the regulators, to expand on that.
Okay. Thank you. I think it's a very, very important question. You have already said it. The issue of enforcement is one of the key challenges we are facing. We are not regulator. We are just supporting, making sure what is entering in our system is of good quality, but we provide the information with all the details to the regulators. But unfortunately, we cannot do much, and we expect that from their side they can act. There are good examples where they get this information 1 week, 2 days to 1 week, they do a national alert. We have seen it recently in Nigeria, but most of the time it's really taking long. And I think that's where we think WHO can play a role, because they really support the countries to ensure that on the other hand, the action is taken. We have seen when the international alert is raised by WHO, it really pushes more on the action. But again, from the time we discover the product and the time WHO raise an alert, it's already enough time, because you have to send the sample for a WHO pre-qualified lab, and without that result, they cannot raise any alert. So it requires an engagement at the country level.
Maybe, Rutendo, you could elaborate on that and also enlighten us a little bit about the problems which are actually there in initiating a very quick response, which I think you are every day aware of.
Thank you very much, Lutz, and Richard as well for the comments. Indeed, it's always a problem for the response from the countries to make the appropriate decisions in a timely manner and in an effective manner. Some of it is because of other local challenges. But one of the things that we realize is there are several factors, and I'll only mention just a few. One of them is the issue of penalties. In other words, when someone is found selling substandard or maybe even falsified medical products, you find that in a lot of countries, the penalties that you can be, the fine, either in a court or maybe the police can issue a ticket, it's very little. So it does not discourage people from dealing wrongfully in these medicines. The other issue is lack of coordination at country level. And one of the things that we realize is there's lack of coordination between the national authorities, the police, the court system, which is the judiciary, customs, and even the politicians. The awareness of politicians of the risk of substandard and falsified medical products is very low. So what we are working on as WHO is we are promoting the development of national action plans, which are multi-stakeholder working to make sure that they all work together. There's a plan which is approved at the highest level within the government. And in Nigeria, for example, they have just come up with their national action plan, and this is being reviewed by WHO, and we're supporting them to make sure that there is multi-stakeholder engagement. And not only those that I mentioned, but also patient groups or civil society will be involved. So those are some of the issues that we do face and as major challenges. And again, as I said earlier, these are some of the things that are being discussed at the summit of the regulators that we have here in India today.
Thank you, Rotendo. Before I move to the next question, I just would like to add a remark from my own experience. We have been working on the detection of substandard qualified medicines and substandard falsified medicines in a few countries. And in Malawi, in Rwanda, in Nigeria, we also had experience that when we were communicating the results through WHO and through the regulators, countries acted quickly and withdrew these medications. So there are some problems we observe, but there are also some very good reactions which we can observe. I think there was a question here. Yep. Then, okay. Okay, please. As a microphone, right.
Thank you very much. Thank you very much for the great session. It's a real particular interesting topic. So very, very thank you for this great presentation. I am Marie Antignac. I am a pharmacist. I'm working in Pitié-Salpêtrière Hospital in Paris, and my particular research topic is about the quality of drugs in sub-Saharan Africa. First, I have a comment and 2 questions, but quick, sure. That's maybe unexpected and paradoxal comment, but I would like to have some information more. Maybe you are Richard. You right when you say that the origin of the problem is probably due to the cost of the drugs, because countries want to buy cheapest and cheapest and cheapest drugs. But in our study a few years ago, there's a 7th study where we performed a study on to assess the quality of cardiovascular drugs in 10 countries in sub-Saharan Africa. We collected and analyzed 1,500 samples, and we analyzed the result, and we can also work on the factors associated with the poor quality. And in this study, we didn't see no association between the price of the drugs and the quality of the drugs. So we have to put out of our head to think that expensive drugs are good quality drugs. That's my comment first. And I have some question. So do you remember probably from the Bates study in 2010, and the conclusion of the BATE study that's on anti-infective drugs in India and in Africa. They conclude, I can read only one sentence, evidence suggests that counterfeiters have learned to include small amount of active ingredient to pass basic analysis and to lure the device. What do you think about that? Now, with the new device, portable device, can be the lure by the incredibly smart and well-prepared counterfeiters?
Okay. Thank you for the comment on quality and prices. And then there was a clear question about detection of medicines which contain a slow amount of active ingredient. And maybe I give this to our colleagues of Oxford University to answer.
Okay. Thank you very much, Marie, for the question. It's a very good one. The simple answer is that it depends on the device and on the medicine that is falsified. But yes, it can bypass some of these devices. There are ways you can avoid this. It would go into very technical discussion, so maybe you can discuss later. But yes, you can bypass. And nowadays, criminals have even in our days have a lot of access to sophisticated technique to make actually very good quality fake medicines. So that's why these devices are very useful, I think, because visual inspection only, it may work, it will work in many cases it's worked, but it will not work for all fake medicines cases, I think. So yes, but very good point, it can.
Would you like to comment on this, Ilya?
Yeah. How does it work?
I think it's already on.
It's on. Thank you. I would like to share one of my research student research work, whereby he collected the drugs for erectile dysfunction from different locations, from mining, from nightclubs, and we screened them by using near infrared. And the interesting part was the library could identify. So in one occasion, instead of putting tadalafil, which is an ingredient for sildenafil, then they included sildenafil. And in a way, it's a very high level of falsification in the sense that the client will get some effects, but it will not last that long. So we were able to combine the near infrared and then coupled with thin layer chromatography, and then we could identify this is a sildenafil and not tadalafil.
I like the combination of near infrared to then also do TLC testing. We have to make short questions because we are approaching already the end of the session. Maybe I'll ask you first, and then you go first. Can we have the microphone, please? Oh, okay. I think this lady was first. Is this okay?
I will be very quick. My name is Sophie Robert. I'm part of the Secretariat of Fight the Fakes Alliance. So the University of Oxford is actually one of our members. I wanted to bring your attention to two things very quickly. So we just released a white paper earlier this summer highlighting some solutions and a lot of the things that our members are doing, civil society, industry associations, to fight the fakes globally. So we invite you to look at it on our website, fightthefakes.org. And second thing, in December, we will have Fight the Fakes Week, and it's a great time to engage around the topic. So we invite all of you to engage with us at that time.
Okay.
Thank you.
I'll take you first, and then the gentleman in the back. And hopefully we'll have time for your question then, and probably have to conclude after that. So please try to summarize shortly.
Okay, it's just a comment. Thank you, wonderful panelists, for the informative and inspiring presentation. This is Hamza Hassan. I'm a pharmacist from Egypt and studying international health master at Charité. 2 years ago, I think we experienced it in my country, unprecedented high incidence rate of anaphylaxis for those who who took ceftriaxone treatment with a very high rate and unprecedented incidence rate. And after investigations, we found that the manufacturing company seems to be not guilty. They are doing everything as a standard. Here we are not talking about highly sophisticated devices like spectrophotometry or whatever. So the company came with a very innovative solution, patient-centered solution to help the pharmacist and the patient themselves to not trust the system, so they can easily check the drug before taking the medicine through a mobile application. The manufacturing company developed a mobile application, can easily be downloaded in mobile phones, so the patient can easily check the barcode of the product, so they can know if it is verified from the original manufacturer company, or it is something fake from untrusted distributor or something.
Thank you for this comment and pointing out this possibility of identifying the authenticity of medicine packages through the mobile phone, actually. We had the gentleman here, and I think first then
Moussa Fofana from Mali, pharmacist. I'm really amazed by this topic since I'm pharmacist and doing importation. I have a question and also an observation for Professor Kali. On the horizon, we have the African Medicine Agency, which is presenting as being the solution for a regulatory harmonized system in Africa. And according to your solution, the solution that you propose in Tanzania and basically in East Africa, how can we translate this solution as a regional solution in Africa, especially in line with African Medicine Agency objectives? Thank you.
Okay. Carl, a very short answer.
Thank you very much, colleague from Burkina Faso. I think the establishment of AMA as a continental regulatory authority is not going to duplicate what functions that are done at the country level, but rather it's going to more focus on the functions that individual or member states are not having strength. For example, like regulation of biotherapeutics, biosimilars, which requires a very highly specialized skills and technologies. And of course, for functions like inspection, which I think many countries have already built the capacities, are going to continue to be strengthened and to be executed at the national level. And I think deployment of things like a mini lab will continue to be a function to be executed at the national level.
Thank you. The very, very last question, very short, then we have concluded.
There's been much talk about digital and AI in this conference. Do you think this is hype, or can you spot ways that this would help you? For example, quick responses, to data spotting patterns, regulating punishment, changing incentives using AI. Any thoughts?
Maybe I take that myself.
Yeah, sure.
Okay. Actually, when you work with spectroscopy, analyzing the spectra by chemometric software is already using AI and machine learning. That's very much in the center of what you're doing there. So yes, it's already entering it, and I think there will be many more points where AI would enter into this picture in future. Raffaela has started our workshop. I think you should be the one to finish it. Maybe I give the final word for you.
Thank you very much. So I also take the opportunity to comment 30 seconds of the remark of Marie Antignac on the prices. Because indeed, you're right, prices are not necessarily reflecting the cost of production. And we know it from the World Health Assembly 2019. There was a resolution which was a little bit forgotten, asking for prices transparency. So this is true at big pharma level, but it's also true of small distributor level. So in that sense, I think that the use of detection, like is done by Professor Kahl and by Richard Nesi, can also help to have local data to dispel some myths that that product is cheap, so it will be of bad quality. It will really help to understand the reality locally. And that's the nice things, that the way these people are using the detection methods is a very technical thing, but they are really informing regulators, they're really informing the pharmaceutical and health systems in their countries about where the problems are and which is the possible prevalence and reasons behind that. And that's, I think, is the very important thing, not to see the detection methods as just something isolated in a silos, but put this into this global way of informing the regulators and the donors and the policymakers. And at the end of the day, it is under the lens of access to medicines. That's very important. For the colleagues from West Africa, at least there is somebody from Mali. There was an old campaign, Les médicaments de la rue ça tue, streets drugs they kill. That's very true. We have to tell people, but we also have to give them a positive message. That medicines are killing you, go there when it will not be killing you. If you don't give the second half of the message, we are not achieving our aim. I give your chair back to the chair.
Thank you. And this concludes our session. Our speakers will be happy to answer individual questions after we officially close our session, which we have to do now to be more or less in time. I thank all our speakers. I thank all of you and everybody who listened and contributed to the discussion. Please join me in a final applause for our speakers. Thank you, and have a safe travel back to all your countries and homes. Thank you.